Alright guys, now that you've had a chance to take a break, we're going to pick up with hyperthermia. Now, as we discussed um, earlier in this chapter, hyperthermia is when the body's heat production is no longer is outweighing the more than its ability to lose heat. Now, there are various stages that the patient will suffer from, such as heat cramps, heat exhaustion, and heat stroke. Now, heat cramps, these are caused by electrolyte imbalances to the muscles, most commonly due to overexertion and hot temperatures with excessive diaphoresis, such as a football player. You know, when we're watching a game, when players go down with cramps, this is what it is, because it's the large muscle groups that are usually affected first, such as the quads. Care for these patients is to try to stretch them out and get fluid back into them. A lot of trainers, they'll use pickle juice or mustard as a way to replace the electrolytes because they are full of electrolytes. Also, that's why they always have Gatorade down on the field as well. Heat exhaustion. This is a mild state of shock, and this occurs when the body's cooling mechanisms have been expended, and the central nervous system and other systems start to show the consequences of this depletion. Patients will present with dizziness and fatigue, with a normal body temperature and diaphoresis. A patient with heat exhaustion commonly has slight alterations in mental status such as dizziness or fatigue, and presents with a normal body temperature and diaphoretic skin. As the patient progresses through heat exhaustion, if they are not treated appropriately, they can move into a heat stroke. This occurs when the body's heat regulating mechanisms have completely broken down and now are unable to cool the body sufficiently. The body becomes overheated, their body temperature rises, and sweating completely ceases in approximately one half of these patients. These patients will also have altered mental status and also potentially be unresponsive. Depending on the severity, mortality can range anywhere from 20 to 80%. Can be caused either through exertion or non-exertion. There are some predisposing factors such as climate, exercise, extremes of age. It's what was discussed with hypothermic. Pre-existing illnesses such as heart disease, kidney disease, Parkinson's, diabetes, obesity, malnutrition, and alcoholism. Drugs and medications can affect you, as well as lack of acclimation to the area. So if you ever go to a new area, you want to make sure that you give your body a chance to get used to it before you go through any strenuous activities. Exercise and strenuous activity can cause the loss of more than 1 liter of sweat per hour and increase in heat production. Exertional heat stroke is the second leading cause of death within high school students. When assessing a heat-related emergency, you want to scan the scene for any evidence that the patient is suffering from a heat-related emergency. Probably the most important factor to consider is the ambient temperature as well as the humidity. Infants and children left in closed vehicles or in structures that are hot and poorly ventilated are also prone to heat emergencies, especially if the infant or child is overdressed and too young to remove their own clothing. Elderly patients, especially those who are not mobile enough to escape these hot environments, are also likely to become victims of a heat emergency. Go through your primary assessment, check your mental status, go through your ABCs. Any patient with altered mental status and hot skin is a high priority patient. Go through your secondary assessment. Try to move the patient into a cool environment as quickly as possible. If the patient is responsive, try to gather a history, paying close attention to the symptoms of which the patient complains. The OPQRST can be modified to gather further information about some of the symptoms. Baseline vitals can reveal a blood pressure that is normal or low. Heart rate and respirations are typically elevated within heat emergencies. Look for your signs and symptoms as you progress into your sample history. Look for that elevated core temperature. Are they cramping? Any weakness? Rapid pulse that is usually that will be strong at first, but will become weak as they progress through the injury. Also keep an eye for seizures and headache, nausea or vomiting. Skin that is either moist and pale with a normal to cool temperature, or hot and either dry or moist. You want to look for those as well. Move the patient to a cool place, such as the back of your ambulance with air conditioner on. If there's no cool location available, try to move them into the shade. If breathing is adequate, apply oxygen to maintain an oxygen saturation of at least 94%. Try to remove as much of the patient's clothing as you can. What you cannot remove, loosen. And you want to try to help cool the patient, but make sure that they don't get chilled to prevent shivering, which thus causes an increase in heat production. So you can apply cool packs, but closely monitor your patient. Okay. You can also try to fan the patient as well to cool them as well. In the patient that has moist, pale, and normal to cool skin, consider raising the feet and legs 8 to 12 inches to improve blood circulation to the brain as well as core organs by reducing pooling within the lower extremities. If the patient becomes nauseated or begins to vomit, place them in a lateral recumbent position. If the patient is fully responsive, we can also consider giving them some cool water to drink. However, if they have altered mental status or are vomiting, we don't want to give them anything by mouth. But that's based off of local protocol. And then try to make a transport decision quickly. Generally, a hyperthermic patient with moist, pale skin that is normal to cool in temperature does need transport when the patient displays any of the listed criteria, such as a core body temperature greater than 100, not responding to any treatment, altered mental status, vomiting, or refusing fluids. If the patient is having hot skin that is moist or dry, this is a dire emergency, and cooling is the highest priority with the exception to the ABCs. We want to try to remove the patient from the source of heat, placing them in a cool environment such as the back of your ambulance. If their breathing is adequate, provide oxygen to maintain an oxygen saturation of at least 94%. If not, apply oxygen to maintain. Try to remove as much of the clothing as you can. You can place cold packs within their groin, armpits, or at each side of the neck and behind the knees. You can pour tepid room temperature water. We don't want it to be too cold, below room temperature, so that way we don't freeze the patient and then cause them to take them from a hyperthermic to a hypothermic emergency. Also, you can fan them aggressively to keep the skin wet to cool them off through convection. Transport these patients immediately. Continuing any cooling methods that you have in tow. Consider calling for ALS. Also be prepared for any complications such as seizures and aspiration. If the patient is having any heat cramps, we want to once again try to remove the patient from that environment. Consult medical direction before giving the patient sips of low concentration salt water at the rate of 1/2 a glass every 15 minutes. If possible, use a commercial product such as Gatorade with a low glucose content. Salt water is made by diluting 1 teaspoon of salt in 1 quart of water. Also, do not give the patient any salt tablets. Try to gently stretch the involved muscle groups. Some experts advise massaging the involved muscles if it does not cause additional pain. Consult with medical direction and follow local protocol when it comes to massage. Also try to educate the patient about what led up to the event and advise them to avoid any exertion for 12 hours to prevent any further injuries. Closely reassess the airway and breathing, and be prepared to establish an airway and provide positive pressure ventilation if breathing becomes inadequate. Also, be prepared to manage seizures with such patients. Their pulse can continue to weaken or the rate can increase further. Make sure that you correlate any changes within your patient's vitals with the patient's mental status. Exercise-associated hyponatremia, also known as exertional hyponatremia and water intoxication, is associated with prolonged exercise or exertion. However, the pathophysiology of the condition is not from an increased body core temperature, but from a depletion of sodium relative to water content and a severe electrolyte imbalance. This will cause cerebral edema or pulmonary edema within your patient. Mild EAH is associated with nausea, vomiting, headache, and bloating, as well as edema to the hands, legs, and feet. Hallmark findings are to assess for in an EAH are a decrease in mental status, fatigue, ill feeling, and nausea. Do not give these patients any fluids, and also be prepared for projectile vomiting. If the patient is unconscious and there's no spinal precautions needed, place them in the left lateral recumbent position. If they are alert, place them in your Fowler's position. Bites and stings, this is something that we will see, that you might see a lot of in this area because of the amount of snakes and insects that we have in the area. Poisonous snakes include pit vipers and coral snakes. Usually if the patient is envenomated by some type of snake, the symptoms usually begin immediately. A poisonous snake bite is characterized by 1 or 2 distinct puncture wounds. The exception is the coral snake, which leaves a semicircular pattern with its teeth as it chews on the skin. These patients, with the exception of coral snakes, have large fangs. They usually have a pit between the eye and mouth, as well as blotches on the skin, with the exception of coral snakes, which are ringed. Many people who venture into the outdoors fear the possibility of a snake bite. However, in fact, such bites are relatively uncommon, and the number of people who die from a snake bite each year is extremely small. The severity of a pit viper bite is dependent on how much poison was actually injected, is gauged by how rapidly symptoms develop. There are several factors that affect the severity of the bite, and coral snake bites can be delayed up to 1 to 8 hours. Factors that could play into it is the amount of venom injected, as well as the age of the snake. Baby snakes, they don't have an ability to control their venom, so when they bite you, most, if not all, of their venom is injected into the patient. The patient's weight and size has a factor, just like with medications being weight-based, and the amount of medication or the amount of medication given is dependent on the weight. If the venom injected is a small amount and you have a large patient, it may not affect them as much as it would in a pediatric patient. Also, physical activity following the bite has an effect as well. The more physical activity the patient occurs or is taking, the quicker the venom is able to circulate through the skin, or through the body, excuse me. With insects, bite, and stings, most of these are not serious from the bite itself. It's the allergic reactions that occur that is the emergency. If they don't have an allergic reaction, they may just have some local signs and symptoms, such as sharp stinging pain, itchiness, tenderness, or swelling to the area. Black widow spiders are the leading cause of death from a spider bite. These spiders have a characteristic black body with a red hourglass marking on their abdomen. Um, Extremes of age, chronic illness, and hypertension increases the risk of severe reaction, and black widow spider bites can be fatal. These bites will cause an initial pinprick sensation, severe muscle spasms, rigidness to the abdomen, as well as respiratory distress in severe cases. When treating patients with a black widow spider bite, you should usually provide general wound care and transport the patient. Brown recluse spider bites. Most of the time, these victims are unaware that they have been bitten because the bite is often painless at first. Several hours after the bite, it becomes bluish, surrounded by a white periphery, and then a red halo or bullseye pattern usually appears. Within 7 to 10 days, the bite becomes a large ulcer as the skin underneath has become necrotic. These bites usually do not heal and require surgical repair in order for the patient to make a recovery. Scorpions. There's only one species within the United States that produces a fatal bite, so most scorpions you don't have to worry about. 90% of all scorpion stings do occur on the hands because people want to reach down and play with them. The severity depends on the amount of venom injected. So, and with scorpions, it's not you get stung once and that's it. They can sting you multiple times, and with each injection, injecting venom into you. Patients that are stung by a scorpion will present with sharp pain, drooling, incontinence, and seizures. Fire ant bites also could potentially cause a large local reaction, characterized by swelling, pain, and redness that affects the entire extremity. It is possible also for patients who are stung by or bitten by a fire ant to have a anaphylactic reaction to it as well. Ticks, these can cause Lyme disease, which is usually transmitted by the tiny deer tick, but now thought sometimes to be caused by other ticks as well. To remove a tick, you want to make sure that you are using tweezers. You want to do this promptly by pulling them out of the skin. Once you get them out, you want to wash the wound with soap and water and apply an antiseptic. When removing a tick, you want to make sure that you get all of it out, including the head. Do not twist or jerk the stick because that could cause the head to be torn off and the removal being incomplete and allowing for anything that is within the tick to still be pushed into the patient. Your priority during scene size up of any type bite or sting emergency is to the protection of yourself and your partner. If your patient has been bitten or stung, you too might fall victim to bites and stings unless you exercise caution. So try to find clues as to what led up to it. If it was a snake, keep an eye out for it. Look for the sounds of swarming bees or hornets. If you hear it, get back in the truck, wait for them to leave. Go through your primary assessment, build your general impression, mental status. Be alert for any signs of anaphylaxis, because this generally has a rapid and life-threatening effect on the airway and breathing status. Go through your secondary assessment, look for those signs of shock. If you do see signs or symptoms of anaphylactic shock, intervene immediately as needed. Also look for signs and symptoms of localized reactions and treat similarly as any injected poisons. While you're going through it, you should also be looking for hives and flushing, faintness, dizziness, generalized swelling, difficulty swallowing, labored breathing, abdominal cramps. Try to maintain a patent airway. If your patient is presenting with any signs of hypoxia, respiratory distress, poor perfusion, or heart failure, and their SpO2 sat is less than 94%, administer oxygen to achieve and maintain an O2 sat of at least 94%. If their ventilation is inadequate, provide positive pressure ventilation at a rate of 10 to 12 breaths per minute. While you're going through your assessment, you should also be looking for any Snake bites. If the stinger is still in, you need to remove the stinger as well. If the patient has an auto-injector for epi, administer it as appropriate per medical direction. Call for ALS and initiate rapid transport. Go through your history. Do they have a history of bite or stings? Um, any redness, discoloration, weakness, or faintness? Dizziness, chills, bite marks, or stinger. If the stinger is still there, you want to scrape in the direction of the base of the stinger to avoid breaking it off below the skin. Be careful not to squeeze the stinger with tweezers, forceps, or your fingers, as doing so can force additional venom from the venom sac into the wound. Make sure you remove the venom sac because it can continue to secrete venom even though the stinger is detached from the insect. Once you remove the stinger, apply a cold pack to the insect bite. Do not apply a cold pack to any snake or marine animal bites, though. Some experts advise the use of a constricting band in the treatment of a snake bite, proximal to the bite, so that way we can try to reduce the amount of venom circulating within the body. Consult medical direction and follow local protocols when it comes to this. Try to keep them calm so that way their heart rate doesn't increase, and reassess your patient. Keep in mind, anaphylactic shock can potentially take minutes to several hours to develop. So while you're going through your assessment, you should be alert to its appearance and be prepared to provide care for this condition. The venom of marine life can cause more extensive tissue damage than that of land animals. Venoms of aquatic organisms are destroyed by heat, so heat should be applied to marine bites and stings. There are antivenoms available for marine bites, so you want to try to identify the animal that envenomated the patient. When caring for patients who have been poisoned by marine life, we're to treat them similarly as those of soft tissue injuries. If any material that is stuck to the patient from the sting site, we want to use forceps to remove it and then irrigate the site with water. Excuse me. If there are any spines that are embedded in the patient, do not attempt to remove them. If the patient were stung by a jellyfish, coral, hydra, or anything like that, carefully remove any dried tentacles and pour vinegar on the affected area to denature the toxin. If meat tenderizer is available, you can also sprinkle the area with it. Doing so helps stop the stinging process as well. Once you've removed the tentacles, you want to apply heat to the area for approximately 30 minutes or throughout transport. When a patient is struck by lightning, these patients are exposed up to 2 billion volts per volt of lightning. The duration of it is 100th to 1,000th of a second, and when a patient is hit, the contact temperature can range anywhere from 15,000 to 60,000 degrees Fahrenheit. Now, is it possible to survive a lightning strike? Yes, it is. I actually know somebody who has survived a lightning strike. When a patient is struck by lightning, what happens is it causes a rapid expansion of air that propels the person. So not only are they electrocuted, but they are also subject to blunt trauma as well as barotrauma due to the change in air pressure that occurs from it as well. Now, there are 4 mechanisms that occur when someone is struck by lightning: direct, contact, splash, or ground. Direct strikes carries the highest rate of injury and death because they are, directly being struck by lightning. In a ground current, the farther the patient is from the strike, the less potential for injury and other effects suffered by the patient. Contact strike, that's where they are, for example, holding on or have their leaned up against a wall, of a building and the building gets struck by lightning. Um, the heart muscle has properties, as we've covered previously, of automaticity, which means that the heart can stimulate its own impulse without the help of the brain. Well, what happens when a lightning strike patient is that the heart begins to beat spontaneously on its own without any intervention. However, the inspiratory centers within the medulla of the brain remain dormant for a much longer time. Despite the patient's heart resuming its beat and regaining a spontaneous pulse, the patient cannot yet begin to breathe on their own. So they go into respiratory arrest, which then eventually leads into cardiac arrest. The patient will have a variety of signs and symptoms depending on the system affected. They may have altered mental status, weakness, amnesia, pale, cool, clammy skin, even mottling or cyanosis. They may have temporary paralysis, seizures, loss of pupillary function. Within the cardiac system, that may cause them to go into ventricular fibrillation, asystole, cardiac dysrhythmias, respiratory distress, and even apnea. Within the skin, they'll have burns and even feathering. These burns oftentimes are superficial and even possibly even partial thickness and full thickness burns. This is caused by the heat or metal heating up on the patient. They may have linear burns, which appear as streaks down the body caused by sweat heating up on the skin. They may have feathering, which appears as a non-blanching reddish-brown fern pattern. This is not a true burn. They may even have punctuate burns, which appear similar to cigarette burns from where the lightning hit them. Thermal burns from the clothing catching fire, as well as various patterns. They may, due to the lightning strike, they may also have dislocations and fractures due to the amount of force and energy that goes through a lightning strike. So this is that feathering that I was talking about, and the punctuate burn. Contrary to common misconception, lightning injuries are not typically major burn injuries. However, superficial linear patterns are common. Their eyes they may have a drooping eyelid or unequal pupils. Because of the amount of pressure that it occurs, they may have ruptured eardrums or tinnitus or even complete deafness. With these patients, we want to try to focus on any damage caused by the nervous system and possible cardiac dysrhythmias. If their clothing is on fire, put it out and remove the clothing. But before you do that, ensure that the scene is safe. Take inline stabilization to the risk of injury to the C-spine. If their mental status is altered, also make sure that you are able to maintain a patent airway. If they are in cardiac arrest, begin CPR per CPR protocols. Attach your AED and deliver defibrillation based off of its analysis. Provide aggressive ventilation with high concentration and transport the patient as soon as possible. High altitude sickness. As you go up in altitude, atmospheric pressure is decreased, which thus makes it less oxygen available. If the patient has any pre-existing medical conditions, this can become aggravated due to the decrease in oxygen. And high altitude illness can occur even in healthy individuals. These patients will present with a general ill feeling, respiratory distress, disturbance in sleep, loss of appetite, and headache. High altitude is anything greater than 5,000 feet. And these are at greater than 5,000 feet is when high altitude sickness will begin to occur. However, serious injury can occur at altitudes greater than 8,000 feet, especially with rapid ascent. High altitude sickness can be prevented by ascending gradually, This allows the body time to acclimate to the altitude. Also, limiting exertion at high altitude, descending to a lower altitude to sleep, and eating a high carb diet can help you also. Ultimately, treatment for this is to get down. Just get down. Acute mountain sickness, this occurs in that rapid ascent to 6,600 feet or higher. These symptoms usually develop within 6 to 24 hours after ascent and worsen if they ascend higher. These patients will present with lightheadedness, weakness, difficulty sleeping, shortness of breath, severe weakness, decrease in urine output, altered mental status, and increased shortness of breath. Excuse me. Acute mountain illness or sickness usually will resolve itself within 1 to 2 days, pending the patient does not ascend any higher. In other words, get down. Just get off the mountain. Try to maintain, try to relieve any signs and symptoms the patient may have, and try to maintain an SpO2 of 90% minimum, because this would be normal at higher altitudes. HAPE, or high altitude pulmonary edema. This is affecting the lungs and gas exchange. What's happening is because of the change in pressure of the pulmonary vessels, it is causing fluid to be forced out of the capillaries and to collect in and around the alveoli. These patients will present with shortness of breath, crackles, wheezing, and at least one lobe of the lung, loss of appetite, fatigue, and even headache. Emergency care for these patients is oxygen administration and to get down. Get down, get down, get down. This can take anywhere from 36 to 72 hours to resolve if oxygen therapy alone is present. High altitude cerebral edema. Now we're over 12,000 feet, and because of the decrease in pressure, now fluid is beginning to circulate or collect around the brain tissue itself, causing an increase in intracranial pressure within the skull. These patients will develop severe headaches, comas, nausea, vomiting, altered mental status. Care for these patients, provide supplemental oxygen with positive pressure ventilation, and get down. Get down to a lower altitude. Alright? Alright guys, that's it for this chapter. If y'all have any questions, be sure to send me a message either in Blackboard or Remind, or be sure to write it down and get it to me next time we are in class. Make sure you're doing your Brady labs. If y'all have any don't have any other questions, I will see y'all next time in class. Y'all have a good rest of your day or evening, and talk to y'all then.